I'm John Porter. I'm the CEO of Parent Project Muscular Dystrophy, and I'd like to welcome everyone to our webinar on the FOR-DMD study. So I'm going to like to introduce Dr. Birch Griggs, who's going to moderate this webinar. Birch is someone that's long had a role in making a difference in this disease. He's professor of neurology at University of Rochester, where he specializes in neuromuscular disease practice. I'd like to particularly note that he's directed an experimental therapeutics training program at Rochester for many years, who has produced many excellent clinician scientists, and it's important his contributions in that area. So Dr. Griggs, along with Dr. Kate Bushby, directs the NIH-funded FOR-DMD study, which is trying to arrive at an optimal steroid regimen, in which he will talk about today. Birch?
So, John, thank you very much, and hats off, actually, to the Parent Project under Pat Furlong's leadership for recruiting you there from the NIH, and I think it's going to be a wonderful partnership and collaboration with the Parent Project with your addition to the team there. Let me just ask at this point, am I audible, John?
Yes. Sounds fine to me. Ryan?
Okay. I just want to make sure everyone can hear me. So the first slide actually tells an important part of the story. So I will just want to highlight that before I make other introductions, to point out that the little boys you see jumping are representative of the flags of the 5 countries that are involved in having patients be part of our trial, in which the goal is to find the best treatment today for a better tomorrow. So if we can have the next slide, please. I'd like to make introductions of the people who will be on the call and asking questions. There's John Porter's already kindly introduced me. Also with us is Emma Chapel Oni, principal investigator in the University of Rochester, a professor of neurology here. Also with me is the project manager, Kim Hart, who actually does just an absolutely extraordinary amount of work for the study. And we're also privileged, I believe, although I've not heard her voice yet, to have Mrs. Melanie Jackson, who is a parent of a boy with Duchenne, and in fact her boy was the first one enrolled in this trial at the University of Rochester, and she and he have been involved with the study for over 2 years. All right, so what I want to do today in the next 20 minutes or so is to tell you about the study, give an update on where things stand, and I want to remind people on why we're doing this study and why the trial is even more important and relevant now than it was when we started. One of the things that's happened over the course of the years that we first designed the trial, and in the 2 years since we started the trial, is that there are other therapies that may become available and are certainly undergoing research, and I want to talk about how boys might participate in those studies as well as be part of our study. Then I want to try to leave adequate time for any questions and answers, because I think that's one of the advantages of the webinar format, is to be able to ask and share your thoughts and questions with us that are running the study. So with the next slide, please. One thing I must point out, and it's very important to acknowledge the fact that the National Institutes of Health, the NINDS, actually John Porter was with NINDS at the time the trial was funded, the Muscular Dystrophy Association, and extremely importantly, the Parent Project has supported our studies with the trial. We're doing a number of other studies that are looking at ways of finding out to prevent bone complications and looking at some of the factors that determine the side effects of corticosteroids so that we'll be able to better prevent those in the future. And so these studies are actually being funded in part by the parent project. So now to summarize the trial, I'd like to go back in history and point out that in many ways it was the parent project that laid the groundwork for this study, because the parent project under Pat Furlong's leadership pointed out that this was over 10 years ago, that there is no standard approach for the use of corticosteroids in Duchenne dystrophy. Everyone knows that they improve dystrophy, but there, in fact, have been multiple different ways of giving steroids, even though most of the data was obtained with only a single way. And I'll come back to talk a little bit more about that, because that is, in fact, the driving force behind why we started the study in the first place and why it remains so important today. This trial, which began over 2 years ago now, is recruiting boys at multiple centers, 39 centers in the United States, in Canada, in England, in Scotland, in Italy, and in Germany. The treatments we are studying are comparing the 3 regimens that are in the widest use in Duchenne dystrophy. There are lots of regimens of corticosteroids that have been tried, but these 3 are the ones that are being used. When we surveyed over 100 clinics around the world, we found that 0.75 milligrams of prednisone a day, 0.9 of deflazacort, and then a regimen of intermittent corticosteroids are the 3 that are most commonly used. And those are the 3 regimens that we are studying. All boys get a steroid. There's no placebo. There's no sugar pill as part of this study. Everyone gets a steroid. And the reason we're trying these 3 is they're the ones that have the most people interested in their use. And I must emphasize that we do not know, and although lots of people have opinions, we do not know which of these agents is best. And that is one of the things we hope to find. And when I say best, the question is best in what way? And best means improving strength and having the fewest side effects. And that is the goal of our study, is to find which improves strength more with the least number of steroid side effects. Recruitment began over 2 years ago and will end at the end of this year. And we've already recruited 63% of boys. The next point is extremely important, and that is one of the major things that we believe that this trial is going to do for Duchenne dystrophy. And that is we're giving standard of care treatment for the entire duration of the study. This means standards of care in terms of treating and preventing complications of Duchenne dystrophy itself, as well as preventing and treating complications of side effects of steroid use. And let me just emphasize, and I'll probably say this at least twice and maybe more than that, because it is so important. Right now, there is no standard treatment for Duchenne dystrophy. If you go to a clinic in one center in this country, it was likely to be different from another center in this country, and it will certainly be different from centers in Europe. This is wrong. In other fields, in cancer, in cardiology, standards of care are widespread, such that if you go into an emergency department with a heart attack in Los Angeles, you'll get the same treatment that you'll receive in New York City. For Duchenne dystrophy, treatments are going to be different depending on what center you go to. Some of you may be familiar with the experience in cystic fibrosis, where cystic fibrosis had similar variation, and it was so serious that in some clinics, patients died in the first decade, whereas in other clinics, they were living into their third and fourth decade. They set up a method to standardize care. And that's one of the things we're so interested in Duchenne dystrophy, is making sure that there's standard care. Because if you have a standard way of doing care, you can improve upon that in the by developing a new treatment. But if everybody does it differently, one never learns anything. And so we want to make sure that the boys in this trial receive what we think on the basis of consensus. A big paper published by Katie Bushby, my co-investigator in this study, co-principal investigator, published several years ago, brought 60 experts from around the world together to develop consensus standards, and that's what we're doing in boys with Duchenne dystrophy in this trial. The things we're looking at in terms of, and the last point on this slide, is we're looking at the breathing capacity, the vital capacity. We're looking at the time to get up from the floor, and we know that that predicts when a boy is going to lose the ability to walk. And then we're also looking at something a survey of patient and or parent satisfaction. This is really, really important because this incorporates the sort of hassle factor of taking a medicine, the side effects of the medicine, as well as the benefit of the treatment. So this is what's called a composite measure, and we think it will give us the best chance of distinguishing between the three different regimens we're using in terms of deciding which is best, both from the side effect point of view and from the efficacy point of view. Next slide, please. So what we hope that this study will do, and we've designed to answer these three questions. What are the risks versus benefit of these three regimens? This will, of course, in the future or in other studies after this one, we might be able to find a better regimen. We might find a different steroid regimen or other treatments, but this will define the best regimen. We're looking at the results if we standardize the management of Duchenne complications and standardize the management of side effects. And we think this is one of the things that has delayed the use of corticosteroids, is the variation in the way people think about how you keep steroids from having side effects. I personally, having used steroids for over 40 years, think that it's possible to prevent most of the side effects. But in fact, this has not been done in many clinics. And so we think that by standardizing care, we're going to be able to prevent most of the side effects that you would otherwise see with corticosteroids. Next slide. This paper is one which we published several years ago, almost 2 years ago, and this was a survey in which we looked at the practices in clinics, over 100 clinics around the world. This is the one I mentioned before. We showed that, in fact, there were 29 different regimens of corticosteroids, and this obviously can't be right. There has to be a best regimen, and that's what we think we are going to begin to define in this study. We also showed that in some clinics, corticosteroids aren't even used because we think it's because people are uncertain about which regimen to use and uncertain about how to prevent side effects, so they say, well, let's just not use them at all. And this has, I think, tragic consequences. Next slide, please. And so this is the answer. I'm asking the question, which many of you may have asked before you joined the call, why are we going to such trouble to study a treatment that we know has short-term benefit but hasn't been studied in the long term like we're doing in this study? We're going to be following these boys for 3 to 6 years, and then we are going to be proposing to the NIH shortly that we'll continue to follow the boys in the clinic to see what effect on the long-term course of Duchenne dystrophy, starting each of these three regimens, will be. We believe then that this may help us develop a standard regimen. We believe it will help us develop side effect prevention in a standard way. And because every new treatment that is being discussed now is combination therapy, always given with corticosteroids, we think that not knowing which is the best regimen makes it difficult to actually know how much benefit exon skipping or stop codon bypass, or the other treatments that are on the drawing board and likely to be approved in the near future, they don't know. They don't know what the best steroid regimen is, and we're going to help to find that. And we're also looking in this trial at studies of how to prevent bone problems, and also looking at the mechanisms of how steroids are working, because we think there may be a better way in the future, a better steroid to design in the future that may be able to get all the benefit of the steroids we have now and fewer side effects. Next, please. This just goes back to our original New England Journal of Medicine paper some 15 plus years ago, and shows the changes in average muscle strength in the first big trial which we did, a randomized placebo-controlled, and it shows 1.5 milligrams per kilogram, 0.75 milligrams per kilogram, placebo and natural history, and shows that the placebo there may be a little tiny placebo effect, but after 6 months it's gone. A steady progression of Duchenne dystrophy without treatment, and then the rapid improvement in strength with prednisone shown in the upper two lines. Notice that 0.75 after 3 months is identical to 1.25 milligrams per kilogram, and this tells us that the minimum dose with the maximum benefit is 0.75 milligrams of prednisone per kilogram per day. And that's the dose that we're studying in our FOR-DMD study. Next, please. So one of the things that I understand, and if I would think about if I were a parent or a physician taking care of a boy and a physician taking care of a boy with Duchenne dystrophy, why start corticosteroids when we may be able to cure this disease with gene therapy? And the answer is, at this point, none of the treatments that are being in clinical trials currently, and none that are even on the drawing board, are likely to be curative. In fact, corticosteroids remain the only treatment that improves strength in Duchenne dystrophy. Eteplirsen, Sarepta's product, shows promise for slowing or perhaps even stopping the progression of Duchenne, but boys do not improve on the agent. So that corticosteroids actually are favorably compared to all other treatments at this point. We hope, as does everyone, that eventually we'll find something that can be given very early and that cures the disease, but we're clearly not there yet. Moreover, as many or probably all of you are aware, most of the new treatments are being developed only work in a subset of patients. Eteplirsen in 13% of Duchenne's, and Adalurin in a similar proportion. Translarma, the PTC product that has been approved for use in Germany and will be likely to be approved in this country sometime within the next year or two. One of the biggest things, though, is that people underestimate the benefit of corticosteroids. Boys walk 30% longer, they stay off the ventilator 30% longer, and we think, looking at the curves that we followed up to 3 years in our boys on clinical trials, that patients' long-term benefit is even much greater. And we now know that, as opposed to the natural history of Duchenne where boys were dying in their teens, we have patients now living into their 20s, 30s, and 40s, and actually going to college, going to graduate school, getting married, having families. And this has changed Duchenne dystrophy from a fatal disease to a disease that is a chronic disease. The boys end up being quite disabled, but they can enjoy life and live productive life for decades now with corticosteroids. And so we think people simply have not recognized how big the effect is. And it's tragic in our viewpoint. In China, for example, 75% of patients never get corticosteroids, and patients die in their mid-teens. And we think that developing standard care with side effect prevention will change the entire world's view of corticosteroids and make a major difference in literally thousands of boys' lives. Next, please. Just briefly and finally, I just want to point out that we're working with Sarepta to allow boys who have exon skipping in trials to participate in both studies, and so boys can stay in our blinded study. We'll be able to unblind the pharmaceutical companies, but we would keep boys in our trial blinded. And as the last point on this slide, we are continuing to allow boys who are on Translarna. That's not available in this country yet, but maybe later this year. PTC Therapeutics is working with the FDA to get it approved. Next, please. So this trial, then, we think will establish standards of care, and we think that by establishing standards of care in this many centers and in this many countries, we will change the management of Duchenne overall, and we'll learn how to prevent the side effects and prevent complications. Next, please. And we want to thank the ppmd, especially, as I mentioned before, for getting new information about side effect prevention. We're collecting blood and urine, which they're helping pay for collecting, storing, shipping, and then we have investigators who are looking at DNA studies and bone metabolism studies, and their support is facilitating our obtaining, having a biobank to make these specimens available for these studies and for other studies from other investigators. Next, please. All right, so I made it through that presentation, and I've tried to leave over half the time for questions. And I see that there are already some questions. I've got to get, John, let me know if I fade out, because I have to look at the questions on the computer, take my face away from the phone.
Right.
So I see Mrs. Jackson is on the call. She wasn't sure if she was doing it right, but since she's on the screen, I think she's on the call. Mrs. Jackson, are you there?
Yes, I am. Can you hear me?
Sure can. So let's see.
I too am on the phone, and I don't know if I'm supposed to pull away to look at questions or I.
So we should. There's already one question. Then that's a correction from the Sarepta trial. Okay, thank you. This is from Genevieve Laforêt. The new Sarepta trial is for exon 45, not 48. That's probably my error there. There's an exon 53 skippable trial and exon 45. I spoke to Ed Kay from Sarepta and evidently got it wrong. Those trials are not starting in this country until next year, but the hope would be that since eteplirsen is now being studied in a big trial in exon 51 skippable patients, that and the Sarepta is hoping that they're going to the FDA hoping for approval later this year or early next year of exon 51. The FDA is wanting them to do studies in other Duchenne exon skippable boys, and so that is the nature of the Sarepta studies and what we anticipate will be starting. And as I said before, we've worked things out with Sarepta. They are as interested as we are in finding the answer to what is the best corticosteroid regimen and best method of preventing side effects, because every patient who takes who's going to receive eteplirsen will also be on corticosteroids, and it's a requirement to be on a corticosteroid to be eligible for that trial.
Birch, there was a question in advance on the web about, you mentioned that you're looking at the complications for bone health. So the question is, with looking at bone effects like osteoporosis and high risk of fractures, Do you know anything about what the most effective steroid regimen might be to inflict the least bone damage?
Well, that's what we're hoping we will find in this trial. There are uncontrolled studies that suggest at this point that deflazacort, although it may have less weight gain, has more problems with fractures. And there's no study that's a comparison where everybody's followed on identical regimens. But some of the data emerging from chronic use of deflazacort suggests that there are more cataracts and more osteoporotic bone fractures. That's not totally established, but we wonder if that's going to be the case. And this trial that we're doing should give us an answer to that question. So I think that tells you my hunch would be that the intermittent regimen, the 10 days on, 10 days off, would have a lower incidence of fractures, but we don't know. And so again, that's the point of the trial, is to use these three regimens and see which ones have the best both efficacy profile and side effect profile. I don't know, John, did that address that question? John Porter?
Yeah, Birch, I think that addressed it. The importance of the information from the trial, can you say something about the importance of standard regimen as background for all the other clinical trials?
Yes. One of the things that we're concerned about is if you start a boy with Duchenne on prednisone, they improve in strength rapidly in 10 days. They then continue to improve for at least 6 months. They then plateau and do not get worse for anywhere from 18 months to 3 years. After 3 years, there is some loss of strength progressively, but we don't know yet how fast that is. We have a feeling that it may be slower than the natural history of the disease. So if you have a boy on corticosteroids and add a new treatment, such as the Sarepta-Eteplirsen or PTC's treatment, if you start them on a new treatment, it's going to be very important to know that if you're looking to see what the benefit is, you've got to know where they are on the prednisone or deflazacort curve. We know that they get better quickly, they continue to improve, and then they plateau for a variable period of time. If you add a new treatment at different points in that curve, you're going to have confusing results, and we think it's going to be extremely important to have a standardized regimen for understanding how to give each of the new treatments. And so that as background for any new treatment, knowing what the best regimen with the fewest side effects is going to be crucial for changing practice in Duchenne dystrophy.
So, Birch, there's another question about bone health. Do you see that posted?
Yes, in terms of bone, are there studies that indicate corticosteroids' effect on bone growth? And that is an issue, and that is one of the concerns that we know that our trial will address. Which steroid regimen is the least likely to stunt growth? Has long been, for over 30 years, there's been a concern that bone growth may be related to the progression of Duchenne dystrophy. And in fact, there was an early study suggesting that a boy that was growth hormone deficient had a much milder course, and that giving growth hormone actually worsened Duchenne dystrophy. So it may turn out to be that growth is, in a way, a two-edged sword. If you slow growth, you may improve dystrophy, and if you accelerate growth, you may worsen dystrophy. That's long been a thought in the field. However, we don't have any real reason to think that actually a steroid that stunts growth to a greater extent will necessarily be better than one that doesn't. So we are monitoring growth very carefully in our study, and we'll be able, I think, to answer over the course of our follow-up which one of the regimens, the intermittent regimen or deflazacort versus prednisone, have the least effects on growth. And so that, in fact, is one of the major pluses of our study. We will be able to answer that question. I would also say that it is important, obviously, for boys to be as normal as possible, and so we think that with appropriate dietary management, we can keep the vast majority of boys from gaining too much weight. Boys want to look like normal boys, and it's bad enough having trouble walking, and then to be fat or have acne or other side effects, or to be very short is a potential problem. We do know that growth, if you compare Duchenne boys with normal boys, as a group they are slightly shorter, that it seems to be part of the disease, that bone growth isn't as great. So that you can't blame that on corticosteroids, it's just an effect of the disease. But I would say, and one of the things I found talking to parents, most parents say, well, look, if my boy is going to be in a wheelchair, does it really matter whether he's 2 inches shorter than he would have otherwise be? And if we can keep him functioning and breathing and enjoying life longer, I'm willing to accept a small reduction in height. I would say that has been true of most of the patients, parents and patients I've talked to over the years. But it's a big concern. You'd like your boys to be as normal as possible, and so we are monitoring growth, and we will have an answer as to which is preferable.
Okay, thanks, Merge.
So another question was answered by Jody Wolf, and are there any nutrition supplements that the boys can't take? And I would say that we've allowed dietary supplements. We have no reason to think that dietary supplements are particularly likely to be of a major benefit. We have restricted, I think, if there were experimental dietary supplements, we have asked that boys not take other experimental treatments, but standard diets we have accepted. I do think that the single most important thing is for boys not to gain weight. And we have, as part of the study, we have very careful evaluation and prescriptions in terms of diet that boys should be taking to avoid gaining weight. Weight gain is a real problem if it occurs. It's part of Duchenne without steroids. Boys often gain weight because they are inactive, and if you can't run around and play, one of life's pleasures is eating, and so you can understand why a boy may overeat. But we think that it's really important not to get heavy because that interferes with mobility, it interferes with breathing, and it has a real harmful effect on the course of the disease if boys get too overweight. There was a question about the ClinicalTrials.gov identifier for the study. Kim, can you provide that?
I don't know it off the top of my head, but if you give me just 2 minutes, I'll provide that.
Okay, the slides will be available, and we can make sure that that's in it. I don't have the exact identifier in my mind either, so Kim will try to find that for us.
So, Birch, another question that we got offline. So while it's important to limit or decrease the side effects, most clinical trials focus on ambulatory boys. So, the parents think in terms of trying to improve or at least stabilize that function, muscle function. How can parents best weigh this trying to limit side effects versus increasing functions when they're making these decisions about clinical trials?
So I'm not sure if I understand the question. When you say decision about a clinical trial, I'm not sure what decision you're asking about.
So,
John?
yeah, sorry, I'm switching back and forth between speaker and headset. So the question is about weighing the options between trying to limit side effects versus trying to improve function.
You're breaking up. I'm sorry, I can't hear.
Okay, sorry, I'm back on headset. So with steroids, a lot of the emphasis is on limiting or decreasing the side effects so that we can take advantage of, I'm trying to interpret the question here, we can take advantage of the value of steroids. With many of the new agents, the emphasis with families is to try to improve or at least stabilize muscle function. So how can the parents best weigh these two desired outcomes of in therapy development, minimizing side effects versus stabilizing function, increasing strength?
Well, that is an absolutely crucial question, and that's one of the reasons that we're so emphatic that it's important for people to be part of this trial, in a sense because none of the new treatments are being given without corticosteroids. And so it's not a question of not having steroid side effects. Everybody's going to be on steroids. And the challenge is we don't know which one they should be taking. And that's so that the companies developing exon skipping and other new strategies for Duchenne, all of them are using corticosteroids. And so you ask them, well, which corticosteroid should we take? And in fact, they say, we don't know. So that's why it is so crucially important to find out which steroid your boy should be taking. And so they're as interested as we are, and I think it's going to be a potential problem for all new treatments, and unless we keep our fingers crossed along with the entire Duchenne Parent Project. Everybody's hoping we will have a treatment eventually where you don't have to use corticosteroids. But so far, corticosteroids are a part of all of the new treatments, and so there's not a question of either or. It's a question of corticosteroids plus a new treatment. So I don't think you can pick a new treatment trial and say, well, I don't want to bother with corticosteroids, because you're going to be taking corticosteroids in both. And as I mentioned at the outset, you can be in both studies. And so we are continuing patients who were in our trial and are going into other trials in our trial. Now, there may be trials that do come up where you can't be in both trials, but the Sareptas, for sure, they've been enthusiastic about working with us so that boys can be in both trials.
Great, thanks.
So now there's another question that will the child be studied on a regimen suggested by the primary caregiver, or will they go through the random steroid regimen for the study? Well, this is a really critical question, and I appreciate the questioner asking. This is from Alpha Kushlani. So thank you for that question. The fact is that the 39 sites that are part of our study all have investigators who recognize that we don't have an answer to the question of which is the best regimen. Ironically, these 39 sites and the doctors involved with them don't know, but some physicians not part of the study think they do know what's the best regimen. And so there are opinions, and as I mentioned, there are 29 different opinions as to what the best regimen should be. And I would have to say, in speaking with people, I tend to blame child neurologists and pediatricians for this. In every other field besides neurology, doctors have agreed that they need to have a standard way to do things. It's been a real problem in the muscle community. And it's not just Duchenne dystrophy, it's other muscle diseases. Everybody seems to have their best way of doing things as opposed to finding what is the best way. And so I can't deal with the opinions of people who are strenuously in favor of one regimen versus another in the absence of evidence. I think that it's time to answer this question once and for all. And we have the irony that in the United States, lots of people seem to think that although deflazacort is not available, deflazacort's the best regimen, they want to take it. In fact, in Europe, where deflazacort is available, we've had absolutely no problem getting patients randomized to prednisone versus the intermittent regimen versus deflazacort. People want to know the answer to the question, recognizing there's something that what's called equipoise. That's what people in clinical trials think is what you have to make it worthwhile studying a treatment. We don't know. It's equal weight on both on the various options, and we simply don't know the answer. So I think for a primary care physician to say, well, I know the answer, I wish he'd share the answer with us and tell us why he believes that, because we're going to a lot of trouble because we're pretty sure that the answer isn't in yet, and we're expecting to get the answer in this study.
Birch, that's a perfect segue into another question. So you're recruiting for the clinical trial now, through the end of the year, right? Through the end of 2015. And so for Melanie, what led her to join the FOR-DMD trial?
I just wanted the answers. I believe I have a nursing background, so I did a lot of research, and my question along the lines of both deflazacort and prednisone are legal in the United, Kingdom and all around the world, but which medication really is best? And I want to help solve that answer, and I also just want, regardless of the treatment, my son is going to be on a steroid, so either way, there's no benefit. I mean, the 10 days on, 10 days off, or is it prednisone or is it deflazacort? It's a 3-year study, and I've seen an improvement in him, so whatever the medication is, if I saw a huge decline in his health, I think I'd think differently about the study, but I'm completely happy with the study as it's going, and we have one more year to actually have the answer, and I feel in my heart if we're helping the community get this answer, then I'm all aboard and 100% for it.
And we certainly appreciate parents like Melanie who recognize that it's important not just for their boy but for all boys to get the answer. I haven't asked Emma Chapel Oni, who's also on the call, to comment. But Emma, do you want to make comments about this issue of the choice of steroid regimen?
Yeah, I think that obviously we do need the help of the patients and the parents to appreciate the importance of answering this question. And I think that the great things about the trial is, like Melanie was saying, that, all these children are being treated, so there is no placebo, so that's a big advantage. They're also receiving a very methodical, standardized care to look at the side effects. And we also know that patients that participate in clinical trials, regardless of what they receive, they always do better. So these are many, many positives about participating. And I think that sometimes, there are some families that they think that, they believe, or some doctors out there, they believe we already know which one is better among the corticosteroids, but unfortunately that is not the case. So I really see it like Melanie, that it's a win-win situation because families and patients, they feel involved in answering an important question for them and also for the larger community. they also receive treatment, and they also receive best standard of care. So, and yes, the visit might be a little bit longer, but I think that, I'll let Melanie talk about that. I don't think they are much longer than a good regular standard of care clinic visit, really. I just see it as really a win-win situation.
I agree.
So we now have a couple more questions to address. One is from Harris Gurdomesis from Greece. Hello from Greece, he says. My boy's 8 years old with a 45 to 47 deletion leading to Becker's. And what is the crucial time to begin corticosteroids? So that is a really good question and a tricky one. First, let me talk a little bit about when to start corticosteroids in Duchenne dystrophy, and then return to the question of Becker dystrophy. In Duchenne dystrophy, we know that if you start treatment at age 4 or 5, the boys do much better rapidly initially and continue to do well, and we've not followed large numbers for their entire life, but we've now followed many patients into their teens and into their 20s and 30s, and we know that the long-term outcome is dramatically different in such patients as it is in patients who don't get corticosteroids or in whom they're started later. So we think, now this is my opinion is that it's better to start as early as possible. There is a study going on now starting the kids very early in life on corticosteroids, and there are anecdotes that suggest starting steroids even earlier may be better, but we don't know yet. That's something that we need to be sure. But what we do know is that if you start steroids early, boys do a lot better. Now the question, and in fact I should say that there is now a push for newborn screening to identify Duchenne early because of the potential to start steroids earlier and to begin treatments like eteplirsen. Eteplirsen seems to slow or arrest the disease, and if you started it at birth, would that mean that the disease never had a chance to get really started? And that's one of the things I think there's going to be a push for newborn screening over the next year or two in Duchenne, as it is in other neuromuscular diseases, starting already for Pompe's disease and starting soon for spinal muscular atrophy. Now, the question about Becker's dystrophy, which is a really good one, our study, all of the boys have Duchenne dystrophy. That's the more severe form, where we know that without steroids they stop walking before age 10, and they can no longer breathe after age 20 unless they're on steroids. Becker patients are more variable, and some of those patients can walk into their 20s, 30s, 40s, even without treatment. And so the question of when you treat a Becker's dystrophy is tricky. And there, if a boy's got a mild disease compatible with a normal lifespan, most of us feel that treatment should be reserved for only cases that are fairly severe as opposed to milder cases. Because, let's face it, even if a boy is on lifelong steroids, this improves things, but it doesn't prevent loss of muscle strength eventually. So that it's a question of the clinical picture more than simply the genetic testing for Becker's. Emma, you have a lot of experience with Becker's. Do you want to comment on that question?
I think that for Becker muscular dystrophy, unfortunately, it's a $1 million question that, how we think of the disease as being all a dystrophinopathy with just, a continuum of disease, or really as a very different natural history. So I think that if you talk with different experts, the issue of treating Becker with steroids or no steroids still remain an unanswered question.
Thank you. So we now have two more questions. Question about that research has shown that it takes a decade or more for physicians to incorporate standards of care into their own practice. once we answer the questions in this study, can we best work within the Duchenne community to facilitate best practices regarding steroid use? And that is a really important question, and one that I'm extremely interested in. As I mentioned at the outset of the call, in cystic fibrosis, the Cystic Fibrosis Foundation worked with their patient registries and other approaches to monitor the data that was coming from their clinics. And that had a transformative effect. Some places, the patients survived only till they were age 9 or 10. In other programs, they lived into their 20s and 30s and 40s. And so just making those observations changed practice over the course of a few years, such that the people that saw that their their children were not doing as well said, hey, we've got to figure out what it is we're not doing that the other places are doing. So I think monitoring the standards, and this is one of the problems of modern medicine, is that doctors have always been reluctant to have their results monitored, but that's changing. The new initiatives in healthcare over the past 4 or more years have meant that we're looking at the results of patients' care, and you can see if one clinic turned out to have patients dying in their teens versus the other where they're living into their 30s and 40s, it's going to be obvious that one place is doing it right and the others is doing it wrong. So I think monitoring the data of the outcomes of patients is absolutely crucial to changing the practice of medicine, and I'm really, really big on doing that. And that's one of the areas that we're going to be incorporating into the next phase of our FOR-DMD study, is thinking about how we're going to do just that, change the standards for care.
So, Birch, you've emphasized repeatedly about getting to a really strong standard with steroids, and mentioned Katie Bushby's paper that came out of the CDC effort to develop care considerations. So our VP for clinical care, Kathy Kinnett, is working on certification of Duchenne care centers, where we're trying to implement those care considerations in sites across the country. So we're trying to do exactly that.
So that's very important, and I think that the entire Duchenne community needs to rally around the issue of making sure that care is standardized. Because one of the things that, having been in the muscular dystrophy research field for decades, I have recognized is the importance of adopting a way of doing things. If everyone does it the same way, a new approach can be developed comparing the new way with the old way. If there are 29 different ways of doing it, at the end of many years, there'll still be 29 ways of doing it. We need to study a small number of ways, show which is best, and then we can develop new approaches to improve upon what the standards currently are. And that's the way medicine makes advances. We make no advances whatsoever if people go by anecdote and their seat-of-the-pants opinion, as opposed to developing the data showing one approach is better than another. Now, the next question that's being asked is there a reason that the weekend dose is not being studied? And yes, there's a very good reason the weekend dose is not being studied. One is we had to pick the most we felt we could study and get answers was 3 different regimens. And when we looked at this issue, when we started the study, there were actually only a very small number of clinics that were using high-dose weekend treatment, and by far the largest number, 20 or more centers were using each of the 3 regimens we chose, and I think only 2 or 3 were using high-dose weekend treatment. I think the high-dose weekend treatment may be a good treatment. The data on it show that it's equivalent and may have fewer side effects. However, when you learn about comparative effectiveness trials, you recognize that the evidence that they actually is equivalent is not that impressive. So we don't actually know whether high dose weekly is equivalent to the others. The point here is, though, that if we get an answer among our 3 regimens, we're not saying that these are the only 3 regimens that should ever be studied. We recognize that there are going to be new approaches, and the high dose weekend could be studied in the future. And so we're not at all opposed to considering that for the future. But we know that if we are successful with our study, we'll answer a question of deflazacort versus prednisone versus one intermittent regimen, and we'll know how to we'll have a standard prevention of Duchenne complications and standards of treatment of steroid side effects.
Dr. Griggs, we do have another question that came in. Mrs. Jackson, are you still on the line?
Yes, I am.
They're asking for a little bit more information about how long the clinic visits last, if it's longer than what your experience was prior to enrollment in the trial. If you could share a little bit about what your personal experience has been and your son's.
I don't really see a huge difference as far as the normal visits went. He gets his, I think at first it was every 3 months. I can't believe, maybe Dr. Chapel Oni would know, and then it was like every 6 months, then we went to a year. But when we do go, it's not bad at all, and he loves going. He loves the environment. He thinks it's fun. They always make it, and, it's a game to him, so he enjoys it very much. And thankfully, we live close to the hospital, that we're able to be a part of this with. I know a lot of families do have to travel, and for those families, I don't see it being any longer than a normal visit would be. So I really can't complain about that at all.
Thank you.
You're welcome.
Okay, Bert. I think we very much appreciate you and your team joining this webinar, and I think you answered virtually every question, if not every question that came in. For those of you on the call, the webinar has been recorded and it'll be posted on our website, Ryan, within a few days, right?
Yeah, it should be within a few days for sure.
Okay.
So Kim, were you able to find the ClinicalTrials.gov?
I was, and I posted that online in this questionnaire and answer area where everyone can see it.
And we'll make sure to add that to the posting when we post it on our website.
Yes, thank you. So I want to thank Pat Furlong and the Parent Project for making it possible for us to join everyone today, and appreciate everybody's attendance and participation. And I want to thank especially Mrs. Jackson for her involvement in the study, and thank Dr. Chapel Oni, who's been actually one of the best sites in terms of participation and involving boys and their parents in the study. And I want to thank everybody for attending the study. Particularly thank you to Dr. John Porter, who's provided both counsel and advice as we've been involved in developing this trial and since he's moved to the Parent Project. So thank you all.
Thank you.
Thanks, Birch.
Thank you, everyone.